center. So we have a few things that we're going to be discussing today. We'll start with the first part of the webinar where I'll be introducing a few things. And the second part of the webinar, Gautam will be talking about some exercises for low back pain. I'm going to talk a little bit before we start. I'm going to talk a little bit about what Gautam does. So Gautam is, some of you may be knowing him if he has treated you for your low back pain before. He is an advanced practice provider for low back pain for a rapid access clinic. This clinic basically is a way to assess low back pain and assess for if surgery is required. Not everybody can belong to this category, but there are certain criteria for that, and Gautam will be explaining more of that in detail later. He's also an advanced musculoskeletal physiotherapist and a McKenzie therapist, which means that he's specialized in exercises and active treatments for the low back pain. And besides being a very good physiotherapist, he has also trained many international physiotherapists. He has helped over 100 physiotherapists in Canada and facilitated over 500 physiotherapists to help them get fully registered. I am one of his trainees. Besides that, he is also a very good mentor and a teacher. He has 18 years of experience in treating low back pain patients. So we are very lucky and happy that he can help us today and teach us some exercises. And so just before we start, I just want to tell you one thing. We are recording this whole webinar, but it's just for the purposes of our training and quality. So you can feel free to keep your video on or keep your video off. It's all up to you. Okay. So moving ahead. So in today's webinar, we're going to be talking about the epidemiology of low back pain in Canada and the incidence of low back pain in Canada. I'll be explaining a little bit about the classification of low back pain as well, and some of the common causes of mechanical low back pain. And in the next part of the webinar, Gautam is going to be discussing some treatment options. All right. If at any point you have any questions or you want to ask anything, feel free to message us in the chat box. There will be a time at the end for live questions to be answered. All right. So moving forward, I'm going to talk about the epidemiology or incidence of back pain, why it's such an important topic to discuss. So as per studies, previous studies, at least 84% of Canadians will experience low back pain at least once in their lifetime. And we also know that this is not a one-time occurrence. It can happen, there can be a lot of recurrent back pain. It's not just an acute episode and recovery from that and it's done. We also know that there's a lot of recurring back pain. And among the gender, it's unfortunate that women face more disability in terms of low back pain. They have more issues as compared to men. And low back pain accounts for more than 1/3 of those individuals who have chronic back pain. Okay. So now coming to the classification, for the purpose of this webinar, we have classified it into 3 different categories. Just for making it simple. So the first thing is called mechanical low back pain. And this is the kind of back pain which responds very well to movement. So any kind of movement may either make the pain better or make the pain worse. And this is the most quickest to recover, and it's the best for rehabilitation. And we're going to be talking a lot about this mechanical back pain in this webinar. The second type of back pain is non-mechanical back pain. Where the cause of back pain is something more serious, there are more serious pathologies that are involved. And this may be inflammatory conditions like arthritis or rheumatoid diseases or something known as spondyloarthropathies, but we are not going to be discussing too much of that in this webinar. And another category of non-mechanical back pain is what we call as red flags. These are conditions which require urgent medical attention, maybe cancer, it may be aortic aneurysm, and things like that, which require urgent medical attention. So these are all the non-mechanical causes of back pain, where the back pain is constant, no movement or there's no position that gives any relief to the back pain because the cause is more medical. And we'll not be covering that in this webinar. And the third type of back pain is what we classify as non-spinal. So here the cause of back pain is not in the spine, but it is in the hip joints or in what we call as the SI joints. These are the joints between the pelvis and the spine on either side. And if there are any issues in the hip, any arthritic changes or any inflammation or any hypermobility or hypomobility, increased or decreased mobility, it can affect the back and it can cause back pain. Besides that, it's also known that if people have limb length issues, that if one limb is shorter than the other, can cause alignment issues and strain on the back and again cause back pain. So this is the condition. These are the conditions where the back is not the main cause of pain, but there can be other issues, and we have to treat them before seeing the back. So this is about the classification. So we are going to be talking a little more on mechanical back pain. So we'll see the causes of mechanical back pain. In most cases, we do not know what is the exact cause. So in 85 to 90% of the cases, the cause of back pain is idiopathic. There's no real pinpoint cause for why the back pain happens. And in other cases, we can directly know that it is after an injury, like an accident or trauma or lifting something heavy, or there will be a particular event which causes precipitates the back pain and which is known to us. Whereas in some cases, it may or may not be because of repetitive loading of the back in awkward positions or poor posture or ergonomics while doing simple daily activities like maybe bending or squatting or walking or anything like that. So, or sitting at the desk. These could be some other causes of back pain. Now, Gautam is going to talk a little bit more about the treatment options that are available for all types of back pain. And I guess he's also going to show us some exercises. So I'm going to hand it over to Gautam.
Thanks, Annabelle. Hi, folks. Hope you're having a good morning, good Saturday morning. So my name is Gautam, and I'm a physiotherapist. I've been helping patients for the last 18 years, and I'm a passionate physio who likes to teach as well. So I hope this session will help improve your awareness and knowledge on low back pain and how to treat. I mean, I don't want you to self-diagnose anything. I just want to give some suggestions and educate you more and make informed decisions when it comes to management. As Annabelle was discussing earlier or telling you before, low back pain has mechanical, so it's simply classified. We simplified the classification because there's so many different classifications. And most times medical doctors like to diagnose anatomically, which means like they want to show, oh, this is what's happening in your spine and your pain is because this is going like this and this is like this. And however, most times that doesn't work. So even though it's an anatomical diagnosis, people like that kind of diagnosis. However, time and again, we tried to rationalize and we failed, meaning if there is a disc bulge, there are like many people with disc bulges, however, they're not having any pain. So the biggest challenge is, not associating your pain with what you see on X-rays and MRIs. Most people think, oh, okay, there is something wrong with my back. That's why I'm having this back pain. However, 9 out of 10 people with anatomical changes, meaning there is a disc that's bulging, there is arthritis in the back, but however, they're not in pain, right? So a lot of people have back pain, but however, I don't want you to associate your back pain with something that you see on X-rays or MRI. That's what I'm trying to make you understand. So how do we then diagnose, right? So that's where, they develop these systems of mechanical diagnosis and treatment, which means we actually put you through a series of not only questions, but also we try and understand whether your back is responding with flexion-based exercises or extension-based exercise, which means a particular direction is helping your back pain. So instead of identifying, oh, okay, there is a disc problem, let's get this disc out, right? That's radical. We don't want that approach. We want more like, okay, what direction of movement is helping this back, or what direction of movement is making this back worse, and then we can try and do simple stretches, not crazy stretches, very simple stretches that can help with the back pain. And again, obviously we want to try conservative management before we go to surgical management. So here for our classification, we graded into conservative and surgical management. So conservative management works for obviously only mechanical back pains. It doesn't work for non-mechanical or non-surgical. Sorry, it doesn't work for red flags or when it's something outside the scope of our practice, which means you need to see a surgeon or you need medical attention for those conditions. So let's go into each of these management things. So say, for example, a person is one thing most low back pain patients resort on doing is rely on passive management. Passive management means there is no form of exercise or no form of stretching or any exercises. You basically do either go for medication or surgery, or you try and get acupuncture, or you go for a chiropractic manipulation, mobilization, you go for physio, but you do more tense machine or IFC, or there is decompression, there is traction, there is laser therapy, shockwave therapy. They're all great treatments, don't get me wrong, but however, they alone cannot be the choice of treatment. So what I'm trying to make you understand is the injections or medications or surgery or these passive modalities. Passive meaning someone is doing something to help your back. So when your back pain is mechanical, meaning something has happened to it and that's the result for your pain, and the mechanics needs to be understood. And then you do the opposite, meaning say, if you have problems with bending forward, if you have problems with lifting weight, if you have problems with sitting, so you have to understand, oh, this is what's causing my problems or increasing my back pain. So what if I do the opposite? So say if you're sitting 80% of the time in your day and you have a lot of back pain and the pain starts to go down the leg. So then what's your choice of treatment? So you can definitely go for these conventional treatments where you do medications, you do injections in the back, you do different traction, decompression, shockwave, laser, they're all good. And then, even chiropractic manipulations, mobilizations, they're all great treatments, don't get me wrong. However, you also need to change the mechanics. You also need to do something to help that reverse. Otherwise, you're lucky if your okay, back sets by itself, meaning it corrects, auto corrects. So sometimes back pain goes away by itself, right? So you don't need to specifically treat it. But other times it may take longer or it may never go away. So it becomes chronic. So single biggest problem is if it becomes chronic, guys, then it's sometimes out of our hands, meaning when it becomes chronic means the tissue has healed, so an injury or whatever is happening has healed, however you still feel the pain. So I will go into the details of chronic pain if we have time. I'm not sure if time permits us, but for this particular webinar, I want to emphasize more on exercise part of the management. So when you see this slide, exercise is number one, and then the rest are all following. They're all good treatments, but however, should not rely on them. So number two is surgical management. So again, people always have, am I candidate for surgery? When do I go for surgery? What makes how do these guys decide that whether I'm fit for surgery or not? How does a doctor decide? How does a physio decide? How does a surgeon decide? So there are criteria, guys, that helps these people understand whether you will benefit for surgery or not. So if you have chronic low back pain, so just plain low back pain, nothing going down the leg, and it's been there for years or several months, surgery cannot be an option. Meaning, no surgeon, and like a good surgeon would never say, you know what, I'm going to treat your low back and I'm going to fix your low back pain. So that's not going to happen. Again, I've been doing this for last 2 years. I treated roughly, or actually assisted roughly 200 low back pain patients under this program. So this is called Rapid Access Clinic, where a physician, a family physician who participates in this program can refer the patient to one of the advanced practice providers. Advanced practice providers for low back pain who actually are trained to assess patients thoroughly based on a mechanical diagnosis. So there are patterns. We classify based on the patterns, based on, again, mechanical diagnosis. We check their thoroughly check them with their neuro, like how their nerves are, if there is too much pressure on the nerves. We check their MRIs, we check all that and take into consideration. And see, the biggest criteria for surgeons is if the pain is constant or if the pain is dominant in the leg. So what that means is the person has leg dominant pain. Either the pain is continuous in the leg or intermittent, but associated with say if I have a magic pill and I can only treat your back or your leg. So if you pick your back, then the chances of doing a surgery for that is less. So however, if the choice is your leg dominant pain, so meaning, oh, I want to get rid of my leg pain, my leg is severe and then I cannot tolerate this anymore. That's when we like and consider the surgical options. Meaning there is scope that there is a small or actually a bad disc that's bulging and actually pushing on that nerve coming on the side. And then if they can go in and perform a microdiscectomy or laminectomy, they can relieve that pressure on that nerve. And the hope is then their leg dominant pain, meaning the pain in the leg gets better, right? So that's why surgery is not an option for all low back pain patients, but it is actually for, say, for example, I was with the surgeons for training. So they see 10 patients in a day. Guys, honestly, they only operate on 1 or 2 patients in a day. So meaning 8 of them are actually not needing the surgery. So that's where they're saying, you know what, why are we seeing all these patients when they don't need surgery? That's what made them enroll into this beautiful program designed by our government health authorities. They designed this program. And this is an orthopedic surgeon. His name is Ram Prasad, and he is the one who designed this program. And in the last 2 years, it's enrolled into the East Division where we are, and we can help people identify if they're correct candidates or suitable candidates for surgery. So sorry if I'm a little fast. I want to cover as much as we can in this webinar. So again, other options for surgery. So say if you have bowel or bladder issues, or if you have loss of sensations on the inner parts of your thigh or around your bum, that becomes a different condition where you have to go for emergency surgeries. So those are again completely numb, and they're like weak, and they're having problems with bowel or bladder. Then they become candidates for surgery as well. So obviously, I'm not trying to go dig deep into the surgical management. There are various options, and one particular situation where they do operate on back specific is, say, if there is very bad instability where there is no scope for that back to stay in position, they may operate to stabilize. That's fine, because it's again the reason they would operate again is if the pain is going down the legs, or if they have weakness down the legs or if they have issues down the legs. That's when they decide to operate. So make sure that you get thoroughly checked and take 1 or 2 opinions if needed. Go through this rapid access clinic program, or you can always get a physio to test you thoroughly, or go through the like I would consider conservative management for at least 6 months before going for surgery. Usually it's 6 weeks, but I would try as much as I can to avoid surgery, because once a surgery is performed, there is no, we cannot undo what's done, right? So once a cut is made, it's never going to be 100% normal. So that should be the last option to consider. And there are so many research studies, guys, that suggest that exercises are superior and they're beneficial than just relying on passive management. And I can provide you with those if you are interested. So again, based on the classification we had earlier, so the mechanical low back pain has again different sub classifications. So say if there is a person who is always having pain with flexion, meaning when they're sitting, when they're bending forward, their pain gets worse, either in the back or down the leg. So they are called, we call them flexion aggravated pain, or meaning bending forward or lifting or sitting is aggravating their pain. And usually extension, meaning the opposite, would actually help their back pain. So we need to look into exercises that are turning the spine backwards. So say flexion is sitting, right? So meaning their spine is in this position where they're slouching or sitting, or when they are bending forward, their pain gets worse. So what happens is, if you want to understand a little bit more, there is pressure on the nerves, or there is pressure on the discs when you sit like that. And then there is a possibility that this can be reversed by doing the extension exercises, which is basically bending backwards. So I will use help of our front desk here. Charlene is our front desk. She can help us go through some of these exercises. Just give us a minute. Charlene? Sam? When you have issues that are actually getting worse with flexion, meaning sitting or bending forward or lifting weights, these are the type of exercises you can try. So you can lie on your stomach. So when you lie on your stomach, you should make sure that you're not in too much pain in this position. If you are, you can try going on your elbows first. So Charlene, so this relieves the pressure, and this is extension, right? Meaning your back is hurting with flexion, which is sitting or bending forward. So you're doing the opposite, which is extension. This can be done in standing as well. So say if you're outside and if you're not able to lie down to do this exercise, you can do it in standing. Lying is better than standing because when you lie down, the pressure is less on the discs and the pressure is less on the spine. So this is beneficial or advantageous if you're at home. You can lie down and get relief. So again, if that's comfortable, you can try even going further back. So and when you're all the way up, it gives even a better stretch for the back. And if you are comfortable, I would recommend you to relax the glutes in this position, relax the buttocks, and then you can come back down. So you can count 1, 2, 3, and then come back down. So this can be repeated up to 10 times. Again, arch back. So again, just be mindful, you need to be diagnosed as a flexion aggravated low back or extension bias, meaning you need to be diagnosed mechanically, and the physiotherapist or a chiropractor should come to this conclusion that this person is getting better with these exercises, and then this can be used as a part of your exercises. So this is exercise number 1. The second exercise you can try is go on your hands and knees. So again, in this position, this is you want to keep the spine neutral as much as possible. So I want you to tuck your tummy in a little bit, and then that's like you're trying to not arch or you're not trying to flex. So you're trying to keep the spine straight, head down. And then I want you to try and kick one leg out. So again, when you straighten the leg, you should not have any pain going down the leg. So these exercises, if you have pain down the leg, we want that pain to be coming closer to the spine or lessening in the leg. And you may feel some strain in the back, and that's okay, as long as it's not getting worse with repetitions. All right, bring it down, shall we? So again, you can try with the opposite leg. And then come back down. So if this is level 1, guys, so if this is easier, so you can also try one arm at a time if you want, just to lift one arm up, opposite arm. So if this becomes easier, you can advance to the next level where you lift opposite arm and leg. So lift one leg, and that's too easy. Then you can lift like a superwoman, right? She looks like as if she's flying. But again, the goal of these exercises is to reduce the flexion bias, reduce the tension on the spine and bring the pain back into the back or eliminate the pain in the back. Okay. So if you have pain that's increasing with flexion activities, flexion meaning sitting, bending forward, or lifting weights. So this is increasing your pain. So that's why you're doing the opposite type of exercises to get relief. So the other simple exercise you can try is lying on your back, face up. So this is called bridging, guys. So again, we are bringing that spine back into the extension. So lift your spine, lift your bum, and then you can see again how she's arching the back. Again, this is an extension based exercise. There are several exercises, but I don't want to teach too many with this session, so it will confuse you. Even one exercise helps, right? So if you want to do just one exercise to see the effect, you can pick the cobra or the sloppy push-up, which is the one that she showed first, or you can try bridging or standing extension. But again, like I said, standing, it's hard on the spine, so usually lying works better than the standing version of the exercises. So these are extension based exercises where the person's pain is getting worse with sitting, bending, or lifting. So the next group of patients is people who actually get worse with standing or walking. So when they're extending, they feel more pain. So when they're extending, walking also causes extension of the spine, or when they're lying flat. So when they're straight, when their legs are straight, they feel too much pain. So for these group of patients, you want to do flexion exercises. So their pain is worse when they're straight. Their pain is worse in standing. Their pain is worse when they're walking. So walking also causes extension in the back. So for them, the choice of exercises is flexion. So meaning bend your knees, Shirley. And you can bring one knee towards your chest and straighten this. So, and then pull to with your hands. So this is single leg flexion, or if this is comfortable, you can try both knees towards your chest. So this is an alternative. It gives such a good relief because it's relieving the tension on the nerves, and they feel better when they're actually bending forward. So these set of patients, they like to sit, right? So they don't like to stand or walk. They prefer to sit, or they prefer to slouch. The biking is a good exercise for them in terms of cardio, and they will benefit with either sitting or stand. This is called flexion based exercises, or they're aggravated with opposite movements, which is extension or standing. So the next exercise in the same position that you can try is bring the legs, we call it table, where the hips and knees are in 90-90 position, and that's one position that you can adopt. So you're tilting the pelvis in, you're tilting the pelvis in, you're tucking your tummy in, and then you're maintaining this position. So hips at and knees at 90-90, and then in this position you can stay there for 5 to 10 seconds, and if it's too easy, you can try and cycle your legs. Right. So also alternatively, you can do leg kicks, alternate leg kicks. Okay. Or you can do mini crunches, which is lifting your head and shoulder up to reach towards your knees. So these are all flexion based exercises. So I guess the choice is again to do either standing or sitting or lying down. In sitting, what you can do is you can sit on a bench or a table or a chair, and then you can do the exercise. So here Charlene shall demonstrate the sitting flexion for us. So she's basically sitting and bending forward. So say if you're going on a walk and you start to feel pain down the leg, then you can sit and then bend forward to relieve that stress on the down as far as you can, and then come back up. So this is sitting flexion. Again, these group of patients, they feel better when they're doing the flexion exercises, and they get worse with the extension exercises. So extension meaning standing, walking, bending backwards. So the next set of exercises. So say when you don't like this, you have back pain for prolonged periods of time, like chronic back pain, or I've been having this for long periods of time. You can try any exercise for that matter, but again, core is one of the important things. So what they have identified is they've done research on back pain, and where they actually put needles in all the muscles in the human body, and then they asked them to move their leg or the arms, and they recorded, right? So they did this on people without back pain, and also they did it with people with back pain. So when they did this study on people with low back pain, what they with no low back pain. So say if you're raising your arm, so most people think that the shoulder muscles or upper body will be working first. However, in the study, it showed that their low back muscles are actually working ahead of the shoulder muscles. So meaning the core muscles are the key in stabilizing the spine. So say if I'm raising my arm, if my core is not stabilizing my spine, I'm likely to fall to that side, because there is no stability in my spine, if you see that. So if I'm raising this arm, I should be falling to this side, if because my weight is distributed more this side. But however, we're not ending up falling because our core is actually stabilizing the spine. So then they also did the same study in people with low back pain. So when they did the study with people with low back pain, they identified that that they have actually trouble with the core muscles, meaning either these core muscles are delayed in firing or not firing at all. Meaning, so they did put the needles again in all the muscles, and then they asked the person to lift their arm or leg. And to their surprise, they saw that the core is not firing in time, or they're not firing at all, meaning they're on vacation. So they're okay, there's too much pain in this area, let's go on, let's not do anything. So they're relaxed and they're not doing their job. Then what happens if the core is not doing their job? The problem is the stability, the stability. So see how these muscles are attached on the sides, and they're contributing to the stability of the spine. When they're not doing their job, the trouble is the load is carried by the spine. So if the load is all carried by the spine, you end up having more back pain. So it's very super important to strengthen the core muscles when you're not in too much pain. So chronic pain, you're always in pain. So unfortunately, you have no choice but to do some exercises, and core exercises are mandatory, because core exercises help to facilitate these muscles and get them stronger. So it's hard to show these exercises because most people think that planks, side planks, double leg raises, all those kind of exercises are the main exercises. However, they cannot isolate the deeper muscles. The core muscles are deep, too deep, and then it's very hard to isolate them. So at advanced physiotherapy, we use a pressure feedback unit, and we use our different mechanisms or methods to show you how to contract the deep muscles and make sure that you're actually doing the deeper muscles versus the superficial muscles, and then emphasize on deeper muscles so that you get the best benefit out of your rehab. So again, it's hard to show it on a webinar, but hopefully we can do another webinar just on core alone. And give you a little bit more input on that. So the next exercise, single best exercise for not just the back pain, but in many patients is like any lower extremity. So people think, oh, I have knee pain, or I have hip pain, or I have ankle pain, or I have back pain, I should not be walking. But however, walking has been considered a single best exercise. Even for the people who have trouble walking, they can use poles, or they can or do alternate ways. But walking is very, very important, guys. If you don't walk, your muscles get wasted, your core becomes weak. So you will get so many benefits from walking. So it is very, very, very important to walk on a regular basis. May it be 5 minutes, may it be 10 minutes, may it be 1 hour. So it doesn't matter how long you walk. The weather is nice out now. The spring is here. Finally, we can enjoy some nice weather. So I hope you all get out there and do some walking as an exercise, especially if you have back pain. You should be walking on a regular basis. Again, some little bit about the chronic pain I will talk about. So if we identify, so in this slide, we're saying if a person has any red flags. So during our assessments, if we identify that the person has non-mechanical pain, and like it looks like, okay, it seems like this person might have some other issues, like a possible aortic aneurysm or a tumor or something else, we definitely want them to get attention. Like not everyone who walks through our door, we can help them, right? So it's you have to pick your battle. So there are people who we can help, there are people who we cannot help. So we have to send them back to the physician or surgeon to get further investigations done. So 9 out of 10 times we say you don't need further imaging, you don't need it's mechanical pain, and we can help you with that. But there is 1 out of 10 patients who actually need to see the specialist. So out of 200 patients that I saw in the last 2 months, last 2 years, sorry, I referred only 10 patients. So meaning 190 patients were okay with just conservative management. So that tells you how many of these patients actually need to see a surgeon. When it comes to inflammation, obviously you may need to consider proper diet, reduce your increase your anti-inflammatory diet and reduce the inflammatory diet. Inflammatory diet is very, it's rich in sugars, your Pepsi, Coke, all these soda pops, they are rich in sugar, so they cause more inflammation. Nightshades, they cause more inflammation. White foods like bread, rice, your noodles, they cause more inflammation. So those are inflammatory foods, and you want to eliminate or reduce the amount of inflammatory foods you eat, like starchy foods like potatoes, they also cause inflammation. And again, non-inflammatory foods are more to do with like wheat, or things like green leafy vegetables, fresh fruits. These are more non-inflammatory in nature. So if you like, I can send you a list of inflammatory and non-inflammatory foods. If you email me the email, like I sent you a link for the Zoom. If you ever, any one of you like to see a copy of inflammatory or non-inflammatory foods, I can send you or share you that information. And then the biggest one is chronic pain. So chronic pain means pain that's lasting longer than 3 months is considered chronic pain. So when it becomes chronic, thank you guys. So when the pain becomes chronic, the challenge is when the pain becomes chronic, the challenge is not just mechanical anymore. So there is some component of the brain involved in it, unfortunately, meaning the pain now is registered, and your brain records every incident, right? That every experience you have, and it starts to judge the pain, and then we need to actually make you understand better and then treat that differently. We won't have time for chronic pain. Let's actually take some questions. So I will unmute the participants, and we can start discussing more on, oh sorry, there is one more slide. So there is non-spinal pathologies. Again, one of the sneaky ones that we often miss on MRIs and X-rays is the sacroiliac joint. So That's the joint, guys. So, which is between the pelvis, so the sacrum and iliac. So this is the joint. So this is your low back, right? So this joint is so close to this area that it can refer pain into the back, and it mimics as if it's a back issue. So a lot of times an X-rays and MRIs doesn't pick this issue. So when we do these assessments, we also check the sacroiliac and identify and then treat it accordingly. And sometimes it's crazy, but if a person has limbal discrepancy or pain in the hip or knee, that can also cause low back problems, right? So these are called non-spinal causes for the low back pain. Obviously, they are mechanical as well and can be very well be treated with the conservative management. So don't forget that that the back pain can often be missed or misdiagnosed, thinking that the pain is in the back. It could be coming from a different body part. And again, there's no one size fits all. Like again, it's not like the exercise that I showed. Full disclosure, guys, it's not that everyone will benefit from my exercises or anything like that. I'm just saying those are the exercises that can benefit based on your type of mechanical back pain. And then again, obviously you want to go to a physio to identify, but with this pandemic, people are scared to go to the physio. They want to have some help. We thought we will do a webinar and educate people with back problems, and so that they can do some exercises to get some relief. However, if your pain gets worse with the exercises, you should stop and report that to your physician or your physiotherapist or your chiropractor, whoever you see, and seek their attention and help. Again, not all treatments are bad. Like I said, there is a place and time for all treatments, and but I don't want you to be relying on those treatments for a long time, right? So again, lower back pain can be non-spine related, where the pain is coming from another joint or another organ sometimes. So say kidney can send pain into the back, pelvic inflammatory disease can send pain into the back, an aneurysm in the aorta can send pain into the back. So there are other causes too. So be mindful of that. If your pain is not getting better with regular treatments, you should always seek medical attention as well. Okay. Okay, we'll open the floor to questions. So if there are any questions, me or Annabelle can help you understand, or let me unmute you all. Okay, anyone can unmute yourself and ask questions. Also, we have a draw here. So we'll draw for, as we advertised in our Facebook, we'll be drawing for a TENS machine. So one of you might be lucky to get a TENS machine today. It's $100 worth that we sell out in the clinic. So that's going to be free for helping you with your pain management. So like I said, this pandemic, it's hard to get treatment. So I thought, we'll do something to encourage people to get treatments at their home itself. So we're doing that as a good gesture. So if no one has questions, Annabelle, do you have any questions?
Yeah, I think it was pretty good what you explained about all the exercises. Yeah, I don't see any questions here in the chat.
I mean, did we miss anything that we wanted to cover in the program?
I think we covered everything. Yeah, covered what we wanted to talk about. Yeah, other things like you said are not in the scope of this webinar, like chronic pain and hip and SI joint issues. There is also one thing that I thought I could just add. So, like you said, the non-spinal issues of pain, there could also be pelvic girdle issues that can lead to back pain. So, women with pelvic girdle pain or pelvic floor issues can also have back pain, and I guess women with back pain should also be screened sometimes for incontinence issues. That is also something that I could just add. But other than that, I think we covered quite a lot. So I don't see any questions here in the chat box otherwise.
All right, so let's do the draw for the TENS machine. So let's see who is the lucky winner.
Yeah.
So I have all the names put in this pile who are registered for the webinar. And oh, okay. So the lucky winner is Brian Parker. Brian, are you there?
I think he's muted himself, but
yeah. If Brian is not there, we can go to the next participant. Is Brian there? I see him in the list of participants. So I will try and contact him. If he's there, we can give him the TENS. Otherwise, I'll move on to the. Oh, okay. His microphone is not working. So
okay.
he is there. He won the. I think he is lucky. He is the first one to join the webinar today too. So looks like today is your lucky day, Brian. So I will actually give you the TENS. If I have a chance, I will also show you how to use it. And we can hopefully help you with your issues with your back pain at some point if you need further treatments. But anyone who likes to register with us or come and have an assessment done, we currently also have a 30-minute free assessment promotion. So I want you to use that option. If anyone is interested, you can put in the chat or email me because I sent you the link. So you can either put in the chat here that you would like to have an assessment done, a 30-minute free assessment. We can do it virtually or we can do it in person. So feel free to avail that option. And then if you actually are okay, we can close this session at this point. If no one has questions, I will hope to see you in another webinar covering another topic or further details into the low back itself. Oh, there's some chat out here.
I think Brian says very informative. Thanks. And
thanks, guys.
Santosh.
Yeah.
Thank you so much.
Yeah, thanks for joining us on a Saturday morning. And
yes,
hopefully, you guys can benefit from our session, and hopefully you guys have a very good rest of the weekend. Thanks, Annabelle. Thanks, Charlene. May Hill, it's been a while. I've seen you there. So hope you're doing well. And I see Nancy here. So thanks, Nancy, for joining us. It was great to see you all guys here. There are a few of my patients who are here. Beverly Thompson, thanks for joining us.
Deborah, thank you.
Deborah, thank you. So it's encouraging, guys. This is our first webinar, and we were like trying to make sure this runs smoothly, and hope we gave a good experience, but might be a little fast. Next time I will try and to be a little bit slower and a bit more informative.
Okay.
Right. Thanks all.
Thank you. Thank you, everybody. We'll stop this now.